Welcome to Cardiovascular Matters. Whether you are looking for answers for yourself or someone you love, we are here to give you the best information available. Each week, the founder of Cardiovascular Institute of the South, Dr. Craig Walker, and medical device sales veteran Terry Roberts discuss the causes, symptoms, treatment, and prevention of health-related issues stemming from cardiovascular disease. Now here's your hosts, Dr. Craig Walker and Terry Roberts.
Hello, everyone. Welcome back to Cardiovascular Matters. We appreciate everyone that has been watching the podcast and has liked and follow us. So if you want to hear about our new podcasts as they are published, just be sure and subscribe, and you'll get notification when those hit. Today's episode, we're going to be talking about when should you go in for a cardiovascular evaluation. Many people come in with questions and they just don't know when the proper time is to take a look and see how things are performing. So Dr. Walker, I'm going to turn this over to you and we'll get started.
Thank you, Terry. Many people ask me all of the time, when should I come in to have a cardiovascular checkup? Mm-hmm. And there are guidelines that the American Heart Association, the American College of Cardiology have put, but these are just general thoughts. And I really think it's not as explicit as it should be. Mm-hmm. So let's speak about when and why one should consider getting a cardiovascular checkup. So we know that cardiovascular disease is very closely related to 5 major factors. So the 5 major risk factors are family history of death from cardiovascular disease, high blood pressure, high cholesterol, diabetes, and a history of cigarette smoking or exposure to secondhand smoke, particularly as a child. Because when one is exposed as a child, there are many, many more years for the toxic effects of cigarettes to impose themselves upon patients. Now, when we look at the strong family history of coronary artery disease and death from heart attack or problems like stroke, we find that is very, very, very closely related to the fact that those people often have higher cholesterol levels. So when should we be checked? Well, clearly, the best treatment for heart disease is to prevent heart disease. That's always better than even the best angioplasty or stent. And I think there's really no time too early to implement that in cases where people have a very strong family history. So if we have someone, whether father or mother or people in the family, died suddenly or had to have heart bypass or things, let's say in their 40s, which certainly we see often, then I think even as a child, some evaluation should be performed. And that evaluation is to look at lipids, to counsel about not smoking, to make sure there is no high blood pressure, to check to see if there's glucose intolerance, and of course, to emphasize the fact that one should not smoke. Yeah. Now, often people don't want to do that early. They say, okay, well, by age 55, I will do this. Here's my cautionary note there. If we looked at Vietnam War veterans who were killed in the war, many of these 19-year-olds, upon autopsy, actually already had fairly advanced blockages in their coronary arteries. So then we would not be doing primary prevention, but rather secondary prevention. Now, as we look at preventive measures in today's world, we have measures to bring down cholesterol, to make sure that we can reduce these risk factors. Certainly, we can control high blood pressure. And so I think there's really no age too young, particularly in someone who has these risk factors. But let's say we don't have those strong risk factors. No one has died at a really young age, maybe has not even died in their 60s or 70s with heart disease. Nonetheless, still the number one cause of death is cardiovascular disease. And so we should pay attention to this. So I think certainly, whenever one is approaching, even with no family history, the age of 40 or so, I think it is very important to have a lipid screen
Right.
looking at the various fractions of lipids in the blood. So lipids are fats. That means the same thing. And so they do not dissolve in water. And blood is basically water with red blood cells and salts in it. And so we would not be able to really carry lipids around, as they simply would not mix. So our body creates something called lipoproteins. And the lipoprotein is a molecule that part of it dissolves in water and the other part can dissolve fats. It's a detergent, if you would. Same reason why we use detergents when we wash dishes, because we're trying to get the fat off of the dishes, and yet it would not dissolve in the water. And so these lipoproteins are many, and they have different functions. But basically, we have high-density lipoprotein, low-density lipoprotein. We have very low-density lipoprotein, and we look at these numbers. And what, is most closely associated with atherosclerosis is a very high level of low-density lipoprotein. That's where we have the most data. Very high levels of low-density lipoprotein is strongly associated with the likelihood of developing atherosclerosis. Now, it has been shown that also there's some protective effect with in many patients who have elevated high-density lipoprotein. However, there are some variants of high-density lipoprotein that also have been shown to create atherosclerosis. So one of the first things in a screen is simply to have a blood test looking at what's happening to the blood fats in your body. And these are cholesterol, basically, predominant that we're looking at, and triglycerides. Those are the numbers. And specifically, we want to see those lipoprotein fractions because we know the one that's most apt to deposit cholesterol into our arteries and start the process of atherosclerosis is low-density lipoprotein. Now, we also know that there's a particularly atherogenic form of lipoprotein, which is called Lp(a). And one has to specifically look for that. That is not in the typical lipid profile. And then thirdly, there's a clear risk factor that has shown up, and that's called C-reactive protein. Now, C-reactive protein is found in people, and it's an inflammatory marker. It suggests that there's inflammation going on within the arteries when we see this. Now, other things can raise. It is not a specific thing to arteries, but large studies, particularly in patients who are known to have some coronary artery disease, shows that lowering C-reactive protein may be as important as lowering the cholesterol levels as well. It has that much importance. And there are many, many research trials going on now looking at what's the best way. Do we have new medicines that can do this? But there's been one long approved medication. It was approved predominantly in the past for the treatment of gout, where we give very high doses of this medicine, but in patients who have an elevated C-reactive protein, this medicine can lower that and has been shown to improve one's health and to lessen the likelihood of going on to have a heart attack. And that medicine is colchicine. When one has gout, we give a lot of colchicine. We give it actually until someone develops severe GI upset. And at that point, the gout generally goes away. Now, we don't do that with colchicine that we're using to lower C-reactive protein. We give a tiny dose, 0.6 milligrams, taken once a day. That typically doesn't cause any side effects, but that absolutely lowers high sensitivity C-reactive protein or regular C-reactive protein. So that's one of the things we'd be looking for in anyone who presents for a screen. Next is blood pressure. And it's interesting. Every patient tells me when we see high blood pressure that it's white coat syndrome.
Right.
People have heard of that. And white coat syndrome does exist, for sure. However, hypertension also does exist. And many of these patients, if we measure a 24-hour blood pressure recording, we see that they have hypertension. And many people, what we can do is an echocardiogram. And if the heart muscle is thick already, it doesn't just get thick for no reason. So that person has real hypertension. So if the heart muscle's thick, or if a 24-hour monitor shows it elevated, then that person has hypertension. And unfortunately, there are a lot of people in denial about this, and that is very, very important. The third risk factor we mentioned was diabetes mellitus. Now, many people think that's only if you have full-blown diabetes and you're taking insulin or you have other big problems. No, that's not true. If we're just glucose intolerant, if we just occasionally have blood sugar getting mildly elevated, not something for which we start medicines, and this is seen very frequently in people who are overweight, that is a risk factor. And controlling that can absolutely improve one's life expectancy and quality of life. And there we've, of course, once again, made great strides in the medicines that can treat diabetes, but also cause weight loss. Smoking, of course, the best thing we can do there is to emphasize just how important it is not to smoke. And, many people believe, well, if I smoke cigarettes, that's bad, so maybe I'll smoke marijuana or do vapes. Well, unfortunately, that's not necessarily the case as well. Some of these here recently have been laced with other things. Unfortunately, one of those things can be even fentanyl, which in very tiny doses can kill. And then finally, the last risk factor, family history. Even if one disowns their parents, you still have their genes. So you've got to work within that. But going all the way back to many, many, many hundreds of years ago, in fact, over 1,000 years ago, Hu Dinao Chang wrote, and I'm paraphrasing in his original textbook on medicine, is that the inferior doctor treats actual sickness. The mediocre doctor attends to impending sickness, whereas the superior doctor prevents sickness. And that is, I think, the purpose of screenings. Being able to go in and speak with your doctor. Now, unfortunately, many people go in for an exam and the doctor says, oh my God, you've got nothing to worry about. You don't need to check anything. I really don't think that's wise either. In a time when deaths from cardiovascular disease is clearly still the number one cause of death, I think it is important to try to prevent. And that's where I think we should focus more as a country in terms of improving the health of the country. Now, I've mentioned we have great measures, but one of those measures we should also employ is a proper diet. Diet and exercise are very important, and stressing these at an early time is important. It's not this ultra strenuous exercise that imparts the health benefit. It's actually fairly moderate exercise done on a regular basis. Things like walking for 20 or 30 minutes, every day, if possible, swimming, those kinds of aerobic exercises. Those things tremendously increase one's life expectancy. So that's the case of when you should come for screening. Of course, if one is getting older and feels chest discomfort of any sort, please don't assume that's always GI distress or it's that you just pulled a muscle. It's very important to check this. Many heart attacks, particularly in diabetics, have no symptoms at all. We call these silent heart attacks. That doesn't mean they're silent to you as a patient. By that, I mean you may not feel it, but it still can kill you.
The damage is done.
Yes, absolutely, Terry. It still damages your heart. It may create heart failure in the future. And so they're not silent for real, other than that you just simply don't feel the pain. Certainly anyone who's feeling the heart racing at any time. That doesn't necessarily mean blockage, but it could. It could also be a symptom of other problems, such as atrial fibrillation or arrhythmias that are potentially problematic. So certainly that's important. Anytime someone snores, they should be checked. Snoring is the hallmark sign of obstructive sleep apnea. When it occurs, if with sleep apnea, this is a big problem because it's associated with so many things: heart failure, sudden death, arrhythmias, atrial fibrillation, you name it. These are big problems. And so certainly anyone who is snored should be evaluated at some point. And the evaluation is not necessarily that big a deal. Of course, typically blood work, that would come into account. If one is having chest discomfort, or if we're having arrhythmias, perhaps something like a treadmill test where an EKG is done, but you are connected to a machine so that you can walk a little bit. Because at rest, the heart may be getting enough blood supply, but if there are narrowed arteries and we can exercise, then it often shows that that patient has a problem. I'll never forget when I first went into practice, I saw a lady who was being treated with all sorts of anti-anxiety drugs. She was in her late 60s, and she had been a smoker. She had high blood pressure. She had high cholesterol. She had borderline diabetes and a family history of heart disease. So I did a treadmill test, a very careful, using a very, very low exercise program. And within 1 minute, she developed chest discomfort. This is a very slow walk. Her blood pressure started to fall. She had arrhythmias. And obviously, that's a very strong test. And obviously, her problem was not nerves. She had critical blockages of her coronaries. In fact, she had a totally occluded right coronary artery. And the left main, which gives rise to the two other coronary arteries, had a critical blockage in it. So this lady was hanging on by a thread to life. She was revascularized, and I danced with this lady later on her 100th birthday. But this speaks about when we should look, because unfortunately, it's not even a screen. It's people who've been followed, and they've known other people. And sometimes this is not top of mind awareness. And many people are treated for these other symptoms with nerve pills, with medicines that decrease gastric acid production because they're told it's heartburn. I can go on and on and on with the other things that it's been caused. But we have to sometimes really take our own health into our own hands. And, an early screen, if it is done appropriately, can be very reassuring. I must tell you, I really strongly encourage my mother-in-law to come in to have a screen. And as it turns out, it was completely normal. And she had been having symptoms, and she was worried about these. It was stopping her from sleeping sometimes. And after I did this, she had a calcium score. That's an easy test. That's one of the screening tests as well, of 0 in her 60s. Now, if you have a calcium score of 0 in your 60s, you're unlikely to have heart blockages. Her EKG was completely normal. Her blood fats were perfect. And I was able to reassure her. Guess what? She felt better. So, being able to know that things are good is also important, because many people sit there and worry themselves to death about these sorts of issues. And, during the screen, if it's a man, it's probably a good idea to get a PSA as they start to get older, to have a baseline study to make sure they're not at risk of prostate cancer. And I can't emphasize enough, during these screens, a discussion should be held with the patient about good diet, about regular exercise, about the importance of controlling all of the risk factors that we've mentioned before. And if we just did this across our country, we could so dramatically diminish the rates of death of cardiovascular disease that it would be amazing. These are things that we absolutely should do. And then finally, whenever one gets into later stages of life, in one's 70s, atherosclerotic disease is a disease of senescence, or a disease of aging. It doesn't have to necessarily be that way. I've seen people that were 100 years old that did not have advanced atherosclerosis. But of course, if you look in that subset, it is going to be higher. but also it pretends a different risk at that level. When atherosclerosis comes on very slowly over years, then often the body has a chance to develop natural bypasses or collateral blood flow. So it is not just whether or not one has blockages, but how rapidly they come up. Because if a blockage comes up very suddenly, then you're more likely to have a big heart attack or a big stroke or other things from that, versus if we have enough time for our body to adapt. That's one of the roles of exercise as well. As we exercise, we develop better collateral blood vessels. And so all of these things are part and parcel of good health. And I think good health is very important. Now, many people say, well, yeah, that's really important for men, but what about women? As many women die of cardiovascular disease as men. And you know what's interesting? Women have less disease of the major vessels. And in another session, we're going to speak about women and the specific things that women should look for when they come in for a screen. Because I cannot tell you how many women I see who are told, oh, come on, you're a woman, you don't have to worry about this. This is just your nerves. I see this all the time. And these women have a problem called small vessel disease.
Right.
Really a focus has come on this in the American Heart Association recently. They've created something called the DAISY questionnaire. But I must tell you, it's a really important issue. And it's why so many women, even though by angiography, don't seem to have as much blockage as men. It's why as many women die of heart disease as men. And in fact, for many years, only recently has this changed again, for many years, more women were dying each year of heart attacks than men. And it is a misnomer. I've seen women insist their husbands and their children come in for care while ignoring their own symptoms. I think it is very, very important to look at this and to discuss this with them, because frequently I would speak to some of these women who had insisted their husbands come in or their children come in and said, have you had any symptoms? And they said yes. Now, some had the advanced atherosclerosis, the advanced blockages that we see on the screen, but many had what we call microvascular disease or small vessel disease. Crucially important we treat that, not just because of symptoms, but it can be a life and death issue.
Right.
So I think that deserves its own challenge. But I think there is really never such a thing as a wasted visit if you're seeing the right practitioner for trying to prevent cardiovascular disease or to detect it early. Like anything in medicine, if we get to this, A, before it occurs, if there are risks, or B, in the early stages, there's simply so much we can do in today's world. We can absolutely lower cholesterol with the tools we have. We can absolutely control blood pressure. We can absolutely help people quit smoking.
Right.
And we can help them with diabetes and diabetic prevention. We just simply cannot change their genetics. That's the one thing we cannot do. But we can take all of those other risk factors, and if we do that, we can improve quantity and quality of life.
Absolutely. You know, you brought up some really good points today. A couple things that hit me that may not be obvious, but the whole thing about secondary smoke. I mean, that should be such a motivating factor. You know, if a mom and dad are sitting in the front seat of the car and they're smoking, and the kids are in the back seat of the car, they're smoking too, because of the secondary smoke. So for no other reason, I mean, you should be motivated to really stop smoking. I mean, I've seen it in my own family, the devastating effects. And, people that should be having a really healthy, vital, meaningful lives into their 80s and 90s, are not. I mean, 60s, they're passing away because of either COPD or incredible heart disease and all the things that come along with it.
Sure, so, Terry, I remember as a child, my eldest brother smoked. I'm the ninth kid in a big family, and he smoked. And he was 19 years older than I am. We'd travel in a car with him. The car was full of smoke. And it was, you'd be choking with that, trying to get him to stop. And at that point, that was considered just okay. That was not such a big deal. But it is a big deal. And we know unequivocally
Right.
that cigarette smoke exposure, the younger one has it, the greater the risk. And so
Right.
I do think that we have to be cognizant of that. Smokers have to be cognizant of that. They're not just hurting themselves,
Their
but
family.
others around them.
Yeah. Well, this was awesome. I really appreciate this information. And as a patient listening to this, one of the things that also impresses me is the fact that most of these things are not painful. The fact that, high blood pressure and cholesterol don't hurt for the most part. So most people, come in to see the physician when there's a problem. Well, you could have a problem and not even know it. So today, the theme of today's podcast was, when should you go in and have these things checked? And Dr. Walker has really laid out a pretty clear story and a lot of evidence around that, just as if you got, especially if you got a family history of these risk factors, you certainly get in sooner than later. But even if you don't, certainly by the time you're in your early 40s, you should have this blood work done. It's a very simple in and out, just absolutely painless, easy thing to do. I've had mine done and more recently have it done very frequently as I've gone through this weight loss that I've been working on. And, the more you know, the better off you are. And the other thing you brought up that I thought was really important is I had one of my cardiology customers, someone that you actually know, and we were working together one Friday or late, and then I heard later that day he presented to the hospital and was having some issues, and they did a heart cath on him, and it was normal. He was fine, but it was other things that that led to that test being done. And I saw him in the hospital the following week on a Tuesday or Wednesday, and I saw him in the hallway, and I said, "Oh, I'm so sorry to hear that." And he goes, "Why are you sorry?" I said, "Well, I'm sorry that you had to have a heart cath." He said, "Man, I'm happy I had one. I know my arteries are clean and you don't." And it just struck me, the overwhelming feeling that you have when you have these tests done and then things come back normal, the peace of mind is absolutely, it sets you free. So, instead of worrying and wondering, my point is to patients, get in there and have this stuff checked out. And Dr. Walker, as always, I appreciate your great expertise and the experience, that you bring to the table to tell the stories. It's not just coming out of the textbook. It's coming out of years and years of seeing patients and the things that you've learned as you've tackled heart disease in your practice. And thank you very much. Everybody, please like and follow the podcast and tell your friends about it. And we'll be back soon with another episode. I bet the next one is on small vessel disease. Thanks, everyone.
Thanks for listening. And please subscribe, like, and share this podcast with your friends and family. Join us next week for new topics and answers with Dr. Craig Walker and Terry Roberts on Cardiovascular Matters.